Dr. Ong is a consultant paediatrician and neurodevelopmental specialist who works at Caringbah. And after graduating from New South Wales Uni, he trained in general practice and actually completed his FRAC GP in 1994. And after this, he undertook paediatric training at Sydney Children's Hospital, and he specialised in child development. And he then underwent further training in England, including at Great Ormond Street Hospital in London, where he gained a lot of experience in managing children with autism spectrum disorders, feeding difficulties, and a whole lot of complex neurological and developmental problems. Currently, he works in practice at Caringbah, and he also provides diagnostic assessments and treatment for a wide range of developmental problems, including autism spectrum disorders, learning disorders, behavioural disorders, and ADHD. He's also a VMO paediatrician at Sutherland and Carina hospitals. And he also does a lot of teaching to parents, community, health workers, mothers groups, medical students and doctors. And he was even invited to run an autism and dyslexia assessment workshop at the University of Malaysia in Sarawak. And interestingly, he's also really passionate about providing access to medical services in developing countries where the poverty and lack of resources stop people accessing any form of healthcare. So he co-founded a charity called Mission for Life Foundation, which works in developing countries like Borneo, Vanuatu, Fiji, Malaysia, and India, and helps to provide services in remote areas, as well as training nurse practitioners and doing community development projects such as providing water supplies, schools, and rehabilitation centres. So with his very busy schedule and his wealth of experience, we were really delighted when he agreed to come and talk to us tonight. So many thanks and welcome, Dr. Ong.
Thank you very much, Janine. Hi, everyone. GPs are actually my favorite group of people because, as Janine said, I used to be a GP, and I basically found that a little bit too challenging. So I decided to take the easy route and become a specialist. And then I took an even easier road out of pediatrics into child development. So thank you very much, and I am excited to be able to give this presentation to you guys. On the screen now, you will see this artwork that was actually created by one of my patients. I think he was about 16 at the time, with ADHD, and he drew this to show what goes on in his mind. And as you could see, lots and lots of different things. And that's typically what the mind of someone struggling with ADHD could look like. Obviously, there are varying degrees of severity, but it could be as complex or severe as what you see in this picture. So I'm going to give an overview about ADHD, and I'm going to talk about management, including pharmacological treatment and non-pharmacological treatment. I'm going to talk a little bit about some of the comorbidities of ADHD, and I will also talk a little bit about some parenting advice that I would give to my families. I have tried to answer as many questions as Janine had sent me. By the way, there were actually 4 pages of questions, so it was quite a daunting task, but I managed to get most of those questions into my slides here, so I hope this will be helpful for all of you. So the prevalence of ADHD worldwide is roughly 5.3% in children and 2.5% in adults. And that's roughly what we're seeing in Australia as well. It's basically 1 in 20, which, if you think about it, is actually very common. That would mean that every classroom would have at least 1 child with ADHD. And the persistence of functional impairment or symptoms into adulthood is actually quite high, about 60%. Now, I've got here the sex ratio, the gender ratio is 4 boys to 1 girl, but we are not really clear about that. And with time, we find that the discrepancy gradually decreasing as we as we continue to diagnose more and more girls with ADHD. And as you can see that comment, there's minimal gender difference in adulthood. So ADHD has got a very strong genetic basis, like many other mental conditions, and the hereditability is about 70 to 90%. So on this graph, you could see that on the right-hand side, the hereditability of height is above 0.9, so it's close to 1. And we all understand that. We basically inherit our height from our parents. But interestingly, ADHD seems to come very close to that. And so if you have one patient with ADHD, there's a high chance that that patient's parents or that patient's children or even that patient's siblings could also have ADHD. Etiology, environmental factors can interact with the genetic risk, but the actual mechanism is still unknown. So on this slide, it just shows the pre and perinatal risk factors for ADHD. We know that cigarettes can cause everything, and included in that is increasing the risk for ADHD. Alcohol exposure in pregnancy, we all know about fetal alcohol syndrome. And I do have a few patients with fetal alcohol syndrome, and they basically have ADHD, as well as a variety of learning difficulties, low birth weight, psychosocial adversity. The psychosocial adversity can often be related to ADHD in the parents and in their families as well. So it is quite it's a condition that has a lot of prevalent issues. This slide shows the executive functions which are impaired in ADHD. So organizing, prioritizing, activating your work, focusing, sustaining your attention to tasks, putting in effort or sustaining your effort and processing speed, emotion, basically regulating the emotions. Here it says managing frustration, which is a very common difficulty, but it can also be a positive emotion, like getting happy or getting excited. These people basically have trouble regulating their emotions to remain a bit more calm, a bit more neutral. And so because they have trouble with that self-control of their emotions, the emotions are more likely to swing either way or in any direction. Working memory is very often affected, and monitoring and self-regulating action. What I often say to my parents is that this is a condition that all boils down to trouble with self-control. And the self-control involves the regulation of emotions, but also regulating activity levels and regulating your attention and your organization, to ignore distractions so that you can continue focusing on the task that does not give the child pleasure. Because we all know that a child with even the most severe level of ADHD can continue doing something that they enjoy doing. And usually it's something that provides instant gratification, like a video game, be it on any kind of screen or watching a video on a screen. the pleasure they get from that drives them to continue focusing on that task. And when they're doing that, they can continue and sustain the focus for hours and not show any signs of ADHD. However, when they're required to do a task that does not provide that instant gratification, does not provide that level of pleasure or joy, where they then have to kick in that self-control to continue doing the task just because they have to do it, and that's where they tend to come undone. And that's, to me, one of the big differences between someone with ADHD and someone who does not have ADHD. The child who doesn't have ADHD can continue sustaining their focus on tasks that don't give them pleasure. So those executive function impairments can then affect their academic performance. So trouble processing instructions, basically trouble taking in instructions, trouble keeping up with their schoolwork because of that lack of focus, and also the lack of working memory, and affect their self-esteem. Because often these kids have average to above average intelligence, and so they're often quite aware that their friends, their peers around them are able to get the work done, but they can't. And that will erode their self-esteem. It affects them socially because they are often impulsive and they can be inattentive when they're relating with their peers. And peers are not as forgiving of an inattentive person as adults would be, and would often gravitate to other children who will interact and respond in a more appropriate way. Emotional, they can be sensitive, they can overreact, and they would have a stronger flight and fight response. This is a very busy slide, but I've included that just to show you the extent of things that can be affected with ADHD. You know, how it actually affects quality of life. So I don't want to spend too much time going through this, but it's just to give you an idea of how encompassing these issues can become. This is a simple slide that shows you the common comorbidities of ADHD. So with ADHD, there's an increased risk of developing obsessive compulsive, well, it is classified as a mental health illness. And therefore, as you know, once you have one mental health illness, you're at risk of having other ones. And that would include OCD, ODD, or oppositional defiant disorder, conduct disorder, bipolar disorder, the learning difficulties like dyslexia, tics, Tourette's, Asperger's syndrome, or autism spectrum disorders. And not just Asperger's syndrome, as many of you would know, is considered to be a relatively mild form of autism. But ADHD is also common in kids with the more severe or more classic forms of autism as well. Anxiety, depression, speech and language disorders or delay, sleep disorders, and many of you would have come across these kids who have trouble initiating sleep, and as you would know that we've been treating these kids with melatonin for the last few years and getting some very good results from that. Dyspraxia, otherwise known as developmental coordination disorder, and substance abuse as well. So one of the things that I guess one of the misconceptions that the general public have about ADHD is that medication treatment can increase the risk of these comorbid mental health issues, especially substance abuse, which is actually not quite accurate. What we actually find is that these conditions are associated with ADHD itself, and medication, be it stimulant medication or non-stimulant medication, actually can result in a lower risk of developing these comorbid issues, except for tics. The stimulants can stimulate tics to declare themselves or to exacerbate existing tics. This is a little bit about oppositional defiant disorder. Out of all the comorbidities, ODD is one of the most common ones, and it occurs in about two-thirds of children with ADHD, and it often develops from around the age of 6 or 7 years. The DSM-5 describe ODD as a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness in children and adolescents. Another comorbidity of ADHD is conduct disorder, which I find is very, very uncommon. I think I've only ever come across one child with conduct disorder, and I feel fortunate about that. I guess a lot of them might bypass someone like me and go on to a psychiatrist. And the main difference between children with conduct disorder and ODD is that kids with ODD are not aggressive towards people or animals. I mean, they can be aggressive, but it's usually a reaction. So it's more reactive aggression rather than calculated or intentional aggression. So these are kids who like, who find, I guess, find it interesting, or maybe even get pleasure out of hurting other people or hurting animals, or destroying property, like setting things on fire, that sort of thing. Whereas kids with ODD are not like that. The last point I've got there, where it says always avoid head-on confrontations, that is the biggest recommendation that you can make to parents to kind of help them manage their child with ODD. These kids with ODD, I think they develop it because of the way that they're being managed in their earlier years, where they've got the ADHD that's kind of developing and causing them to get into more and more trouble in their preschool years. And so by the time they're 6 or 7, their self-esteem is eroded. They feel that the whole world is against them, and that's why they react in this way. They argue because they can't be bothered to do something, or if they don't argue, they become defiant, where they just won't do as they're asked. Because it could be because every time they try and do something, it fails. It's not good enough. And it causes them to feel that they're not good enough. So why even bother? And so they would often try to get into an argument to argue their way out of doing something. And parents are often, I guess, taking the bait to get drawn into an argument and end up, I guess, taking focus away from doing the task that they were asked to do in the first place. So one way of managing that is to not argue. And what I say to parents is that, put out your hand and say, stop. I've asked you to do this, right? If you do it, this can be your reward. If you don't do it, this will be the consequence or punishment. I'm going to go away, but when I come back in a minute, you tell me what you've decided to do. And by doing that, they have not allowed the child to get away from doing the task. They've actually avoided a head-on confrontation. And hopefully, the child is therefore able to remain calmer, think about it, and hopefully make the right choice and then move on. So I've just put this slide up because, this is how a lot of kids with ADHD, plus minus ODD, end up feeling, because of that lack of performance. It's like they try to do something, but um, because of something beyond their control or beyond their ability, they're not able to do it. And so they often would then feel like they're worthless or they're bad or dumb or lazy. And that's what I often hear when a child is getting into that argument with their parents and they end up saying, I'm dumb, I'm stupid, I wish I were dead, that sort of thing. This slide shows what's happening in the brain with ADHD. So it's a prefrontal cortex that's the main part of the brain that is affected in ADHD. And then in the center picture here, you've also got the basal ganglia that are also affected, but I guess maybe less directly. But the amygdala, which controls emotions, the cerebellum, which besides controlling balance, also controls sensory processing, and often these kids have trouble with their motor coordination skills, which is what the cerebellum is responsible for, and also sensory processing issues. These kids are often sensory seeking, we call it, where they've got to touch something, or when they're interacting with someone, they'll run into them, they'll crash into people, or they like rough and tumble play because of all that physical tactile sensation, which they enjoy. The main neurotransmitters that are involved in ADHD are noradrenaline and dopamine. And that's what the medication does. It basically increases the levels of noradrenaline and dopamine in the neurons, especially in that prefrontal cortex. So, pharmacological treatment. So this is the list of the ADHD medication that's available here in Australia. In America, the list is almost triple that, but here in Australia, those are the main drugs. So that's methylphenidate, and in its basic form comes as Ritalin 10, which is a 4-hour immediate release tablet. Basically kicks in within half an hour and will last for 4 hours, and then it simply wears off almost suddenly. And so Novartis have come out with Ritalin LA for long acting, which is an 8-hour capsule, and it's a sustained release form which kicks in within half an hour and will last for usually about 7 hours and not quite 8 hours. Concerta, produced by a different pharmaceutical company, is a 12-hour sustained release version of methylphenidate. And that 12-hour coverage, I tend to use that in the older kids, like the ones from year 6 and above, where they've got more homework to do after school and therefore require a bit more medication to help them concentrate on their homework. Dexamphetamine is also a 4-hour tablet. Side effects are very similar to methylphenidate, so those two drugs are actually very, very similar. Dexamphetamine LA is a sustained release form of dexamphetamine that some compounding chemists are able to make and put together as either tablets or capsules for patients. And then there's Vyvanse, which is a 12-hour preparation of dexamphetamine. Atomoxetine. So we're now moving on to the non-stimulant medications. So there are basically 3: atomoxetine or Strattera, guanfacine, and clonidine. With the non-stimulants, their effects are supposed to last 24 hours. They have to gradually build up in the body over a period of a few weeks. Strattera can take up to 8 weeks or even slightly more than that to produce maximum effect. Guanfacine can take up to 4 weeks. Clonidine, it's much quicker. It's usually just a couple of days. This slide here just kind of summarizes the modes of action. So methylphenidate, amphetamine, and atomoxetine, they all mediate noradrenaline and dopamine. And so they affect the noradrenaline transporter. Methylphenidate and dexamphetamine also affect the dopamine transporter. And so that could be a reason why these two stimulants are more effective than atomoxetine. An additional thing that dexamphetamine does is it also increases the presynaptic release of neurotransmitters, which they think that methylphenidate does not do. So you could even say that dexamphetamine could be more potent than methylphenidate, which is something that we do see in some patients in terms of side effects, the emotional side effects, I mean. I thought I'd just spend a bit of time talking about guanfacine or inattentive because it's fairly new. It's only been available in Australia and on the PBS for the last year and a half, I think. So guanfacine, like clonidine, is a central alpha-2 adrenergic receptor agonist that is supposed to treat the main areas of ADHD. So it does increase concentration, and it does reduce hyperactivity and impulsivity. And it can also help with emotional sensitivity, the hyperarousal, rejection sensitivity, and social aggression. It's an extended release tablet. So where clonidine is not extended release, and the duration of action is only like 2 to 3 hours. Inattentive, being extended release, is supposed to last for up to 24 hours. Side effects: drowsiness, hypotension. And so some of you as GPs might have been asked by your patients' pediatricians to check their blood pressure in the initial weeks when inattentive is being introduced and sort of built up in your patient. I find it to be quite uncommon, but I have had just a couple of patients where they've had significant hypotension in the sense that, they're just, um, um, they're getting quite dizzy when they stand up, so experiencing postural hypotension, and therefore have had to stop the medication. Drowsiness is a more common side effect, and it's something that can last for a couple of weeks even, which can be quite annoying and can end up being a reason for stopping the medication. Even though it causes drowsiness, I've had patients who can have trouble going to sleep or have trouble waking up in the middle of the night. And that tends to occur more often if the patient is taking it in the evening. So I generally ask patients to take it in the morning, because from the information that the pharmaceutical company have provided us is that 85% of the medication is released in the first 12 hours, which will mean that you have more effect in the first 12 hours. But they also tell us that it can be given in the evening because of the drowsy side effect. So if I have patients who develop drowsiness, I get them to take it at night, which might help them fall asleep. And then I may then get a few patients who then have trouble waking up in the middle of the night. And then we may need to make some changes to this. Right, on to non-pharmacological treatment for ADHD. Look, there are lots of things out there for treating ADHD without medication. And so I've just compiled a short list of the more common things that are available. So psychological intervention, very, very important. And I do send a lot of my patients with ADHD to a child psychologist. Because their parents need help with behavior management strategies, especially the ones who have kids with additional ODD. When you have a child with ADHD and ODD, you'll find that it's actually the ODD part of things that are more challenging to manage and put up with, as opposed to the primary condition of ADHD. Now, because it's the ODD part where you get all the emotions and the anger and the fighting. And so a psychologist can actually help. The thing about, I guess the thing to point out about psychological intervention in children is that young children do not really respond to cognitive behavior therapy, simply because they lack the insight or self-awareness for CBT to be effective. So what would often happen is that they'll just agree to everything that the psychologist says to them in their office, and once they've walked out the door, it's all forgotten. So a lot of the counseling should be directed to assist the parents, giving them additional understanding as to why their child might get upset, and additional strategies to, I guess, prevent the child from getting upset too often, and also how to manage that child when they get upset. Occupational therapy, I find, has got limited effectiveness in treating a child with ADHD. If the child has got a lot of sensory processing issues, like the sensory seeking that I talked about, which is becoming annoying to other people, or if the child has a lot of sensory defensiveness, like sensitivities to noise, or sensitivities to other forms of sensations, like to touch, or like clothing, or to food and fussy eating and all that kind of stuff, then occupational therapy can help those sensory processing issues. Occupational therapists can also help with the fine motor skills like handwriting, which a lot of kids with ADHD have trouble with. And they can also help with general tabletop skills, like copying things down from the board and trying to focus their attention on something that they're doing on a table. But I do find that success with occupational therapy without assistance from medication can be quite limited. Supplements. Now, there are all kinds of supplements that have been marketed for ADHD now. But I think that the only one that has good quality research to kind of support them are the omega-3 fatty acids. And if, in case you're wondering which brand of omega-3 fatty acids should we look at, the one that I recommend is called IQ. So that's spelled EYE, the letter Q. And they've recently changed the name to Equazen, EQUAZEN. And the reason I recommend that brand is because they did quite a lot of research in children in the UK taking that particular product, and they found that after 3 months there was a measurable improvement in their concentration skills. In children taking that particular product in 1/3 of those children, which meant that it didn't work in 2/3, but there was a 1/3 chance that it helped. And that research has also been replicated in Australia with very similar results. And so that's why I recommend that particular brand, which most chemists don't carry. So to actually get hold of that, I get parents to Google it and order it from an online pharmacy. Diet. There has been lots of research done on diet, and basically the consensus is that it's artificial chemicals, preservatives, flavorings, additives that if a child is that some children are sensitive to. Most are not, but there's a small percentage of children who are sensitive to those chemicals. So what I do say to parents when they ask me about that is that, well, try to minimize the amount of preservatives and additives in the food that your child has. And a lot of them have already tried doing that by the time they see me, and they found that it has not made much of a difference. But there will always be some child who, if they actually eat that, there's a little bit more hyperactivity, or there's a bit more emotionality. Caffeine is a stimulant, like the psychostimulant medication. And so, yes, it can actually treat ADHD and improve concentration and all that. So a lot of those coffee addicts out there, when I hear someone saying that, oh, I must have my coffee, otherwise I cannot start my day, I cannot function at work, it rings alarm bells in my mind. The problem with and this would not just be coffee, but the energy drinks, like the caffeinated energy drinks like Red Bull and Mother and V and all that stuff. But they can be highly addictive. So if you have a patient who's addicted to caffeine, that patient could have underlying ADHD. So it's something worth thinking about. Working memory training, there's been a lot of marketing and hence research done about the two common companies that have brought out the most common forms of working memory training that you do online. CompMed is very expensive. You're talking about around about $5,000 for a 5-week course. And it makes a lot of sense that they try to improve a child's working memory. The problem, though, is that even though on the program they make huge improvements and are able to, say, repeat a sequence of 9 numbers going backwards, which most people like you and I will struggle to do. That still does not generalize, towards their everyday life, their ability to just focus and concentrate in the classroom. And the same sort of issue is coming out of biofeedback training. Biofeedback training can cost anywhere between $3,000 to $8,000, depending on which company you go for, and it takes a few weeks of training where the child plays a particular game on a computer. There are electrodes connected to the child's head to the computer where it's kind of monitoring the brainwave patterns, and so the premise is to try to develop a certain pattern of brain waves that is what they would normally see in a child who does not have ADHD, by manipulating the game through monitoring the child's brain waves. And there have been quite a number of my patients who have actually tried that before coming to see me, and even some who have actually tried it while they're still seeing me and on medication, and not a single one has been able to say, oh, it fixed my child. As soon as the course is over, everything kind of goes back to the way it was. So with psychological intervention, there's now a lot of psychologists, including occupational therapists, are doing social skills training, which I agree is a very good idea. So social skills training focuses on developing and reinforcing the use of appropriate social skills, like for communication, for cooperation, emotional regulation. Some people in 2007, Debu and Prince, did a systematic review of social skills and found that social skills training does improve these aspects of social functioning in children with ADHD. Parenting and behavioral intervention, like what I talked about earlier on. So it involves manipulating environmental factors that are antecedents or consequences of the maladaptive behavior. So trying to manipulate the environment so that you prevent the bad behavior or the emotional outbursts, for example, from developing, and also consequences, how to manage when the child is upset. Right? What we do understand with ADHD is that poor parenting does not cause ADHD, because the cause is genetic, but poor parenting can make it worse. Chamberlain and Patterson, back in 1995, already found that poor parenting, is the most robust indicator of negative long-term outcome. ADHD contributes to impairment in the parent-child relationship and stress among parents. Basically, if there's a child with ADHD in a family, there is automatically a 50% chance that their parents will separate for whatever reason, but it comes with the territory, unfortunately. And down the bottom, there was this randomized controlled trial comparing the Triple P parenting program, the positive parenting program, with families that were on the wait list and who basically didn't get to do the Triple P yet. And what they found was that the parents who did do the program reported lower levels of disruptive behavior at home. But at school, the teachers found no difference. So this is just some information about the working memory training that I've already talked about. The biofeedback, that's what they call neurofeedback therapy now. And I'll just skip that because I've already covered most of that. Diet. So I have also covered that. And so this slide is an overview. So of, I guess, more practical things that one can do. So, so in the first column, what can be done to support weak or poor working memory? Well, reduce the cognitive load. Reduce the amount of work that they need to do, or break it down into simple steps, and that in itself is reducing cognitive load. Use a notebook or a diary. Use routines. Routines and structure are very important and can be very useful. Use a multi-sensory approach. So use visuals like visual timetables, or photos and pictures. Use short instructions. Modify your presentation of material. So and so you can. I'll let you kind of look at that in your own time, but this is something that you could easily reproduce. Just print it out and give it to a parent with a child with ADHD. What I find with a lot of parents of children with ADHD is that there's a high incidence that one of them also has ADHD. So they also have trouble struggling with a big cognitive load. And so we have to keep things simple for them as well. And I think this is something that is simple for a lot of parents to look at and try and follow. So conclusions about the treatment is that effect sizes for all non-pharmacological interventions are weak. The numbers in a lot of those studies are also very small. So those studies are not that powerful. But basically, the effect sizes, the actual, I guess the actual effectiveness isn't that great. Where I said that the omega-3 fatty acids showed a measurable improvement in concentration skills, there have been studies that have compared that with the stimulant medication, and they found that stimulant medication caused a 4 times more increase in concentration than the omega-3 fatty acids did. And what I have found in my experience is that a lot of parents who are concerned about pharmaceutical medication are very happy to put their children on that particular omega-3 fatty acid. But unfortunately, a lot of them are still coming back saying that, yes, it has improved the concentration, but only by a tiny bit, and it's still not good enough. Okay. So down the bottom, ADHD children do not have a skill or knowledge deficit. A lot of them are very bright and very intelligent, and a lot of them even have IQ in the superior range or the gifted range. But what they have is a performance deficit. So, you need to role play and practice. You need to drill the skill. So, parents need to do a lot of repetition and do a lot of modeling to help their kids. So now these next few slides are going to be about some parenting tips that you can share with your parents. This is what I share, and And this is stuff that I've gathered from various books and talks that I've listened and read about parenting. So number one, children deserve two gifts from their parents. One is love, and the other one, limits. So love is the obvious thing, but limits, discipline is the other one. Because a lot of parents have trouble placing limits, boundaries on their children's behavior. And a lot of parents, as you know, would kind of be parenting out of their own experience from the way they were brought up. And although there may have been some strategies or techniques which were effective and positive, there would also have been strategies and techniques which were not effective. But because that was their experience, they think that that's the way to go. So I do encourage my parents to actually look out of their own experience and be teachable. Look at books and talk to other people and find out, what are better ways of managing their children. Boys, I've written their courage because I think that's what uh, you know um, that's what is in the heart of boys. What they really, really want to know is that, do I have courage? Um, that sense of courage is something that seems to validate boys. With girls, it's beauty. I know it seems superficial, but I think, again, from what I see and learn from my patients and families, that girls place a lot of value on beauty, and they basically wanted to know that they are viewed as being beautiful, not just outside but inside as well. And together, those two qualities are how boys and girls value themselves. And as parents, that's what they need to help their children understand that if they've got boys, that their boy is courageous, that their boy has got what it takes. You know how boys are always saying, "Oh, look, mom, look, dad, look what I can do," and they're trying to ride a bike without holding the handlebars. That sort of courage. I've put in there fathers, because fathers play such a huge role. I think men don't quite understand that they are the most powerful figure in their children's lives. They might think that mom is, but I think if men actually, or fathers actually, understood that they're the most powerful figure in their children's lives, then maybe they might actually spend more time with their children. What I see from my families with ADHD is that it's basically about 10 to 20% where the fathers will come to the appointments, and the rest of the time it's the mothers bringing their children. And unfortunately, I have quite a few families where I've never ever met the father, even though I've been seeing their child for years. But what I do find, and one day when I get some time, I'm going to do a bit of research into this, is that those fathers who show up to the appointments, I'm finding that their kids tend to be more successful, by the time they reach adulthood. Successful in all ways, and not just academically, but just as young men and young women have got a positive attitude on life, have got a positive attitude with their work ethic, have a positive self-esteem. And I think it's not because the fathers just show up to the appointment, but because those who show up, it kind of shows that they are playing a bigger role in their children's lives on a day-to-day basis. I believe that fathers actually bestow a lot of identity to their children and give them a direction, in which to go in their life. So I do encourage my parents to get their fathers involved in being with their child, and spend quality time, talk and teach. A lot of people think that kids are beautiful and cute when they're young, especially in the preschool years or in the primary school years, but wait until they're a teenager, and brace yourself for what's going to hit you when your kids are teenagers. And I looked at that as a curse, which is totally it can be very true, but I think it can be prevented if they were to actually invest in spending quality time with their kids when the kids are young, and not just be a great playmate or friend, but actually teach them the values that the families have. Teach them what's right and what's wrong, and teach them not to follow your peers, because they're all dumb kids anyway. Follow the wisdom that the adult parents can actually give them. And by doing that, by the time they go into high school, the relationship is so strong that their teenagers will actually say no to the other voices that they get from their peers or even some teachers, and they will just kind of continue to follow what their parents are trying to advise them and teach them. And you'll find that, or they'll find that their life with their teenagers can actually be extremely positive. One thing I tell all my families is that don't ever give them ownership of a mobile phone or a screen or a tablet or a computer or even a car when they're 17 years old. You can buy it, all right, but as parents, you own it, and you can lend them to your kids, and your kids can get to use them by accumulating credits or stars that will have a value of so many minutes on these devices. And that way there'll never be an argument when they have to hand these devices back to the parents at the end of the day for charging, so that they don't go to bed with these devices. And if they could start that right from the beginning, then you'll find that less arguments can occur as they go through. This is something that I love. The 5 Love Languages by an American psychologist, Gary Chapman. If you were to Google that, you'll come across his books very easily. And he started off with these 5 love languages as something to help the relationship between a husband and a wife or partners. But he's now written books that are that I guess are relevant towards for parents in growing the love or the relationship with their children. And basically, what he's saying is that people, including children, have 5 primary love languages, right? Everyone has what they call a love tank, and every time your love tank is filled up, you feel validated and valued. It basically makes you feel good. And so because we're all different people, we have different levels of these 5 love languages that we operate in, but we all have at least one of them in a bigger way. And so I would give this information to some of my families, and I will say, look, can you figure out which one of these 5 describes your child? And if they don't know, what they can do is just talk to that child, share it with them, and their child will be able to tell them which one appeals to them. So just quickly, the first one is quality time. So that's just spending quality time with the parents. And so if you wanted to discipline a child whose love language is quality time, then you can do it by withdrawing a section of time, and that will be more impactful on the child than something else. The second one is gifts. So receiving gifts from the parents. It could be something very simple. It could be like for a girl, it could be a flower that you pluck off your garden, or it could be just writing a message on a card or something. It doesn't have to cost money, but whenever such a person receives a gift, it really builds up their love tank. And therefore, to discipline them, you could withdraw something from them for a period of time. Acts of service. So people doing things for the child, or the child helping others and doing things for other people. And those kids like to do things independently. So you can discipline them by removing the freedom to do something on their own. Number 4, words of affirmation. This is a very common one. Receiving spoken or written encouragement, good on you, that was so good of you, that was great job, things like that can mean a lot. So like I've got 2 girls. One girl is her love language is words of affirmation. The other one is gifts. And what I see is that if I were to give a gift to my daughter, whose primary language is words of affirmation, she'll look at it and say, "Oh, gee, thanks, Dad," and that's it. But if I don't say, "Oh, look, you're great and you're beautiful," and whatever it is, if I don't give her some positive words, she'll think that I'm not happy with her. And the reverse will happen with my other daughter as well, because their love languages are different. And the 5th one is physical touch, being physically close. And you can discipline by removing contact for a little while, like putting the child in timeout. I think this also operates the reverse way, where if a child were to grow up and their love tank is not being filled up by their parents. So for example, if my daughter, whose love language is words of affirmation, hardly ever gets words of encouragement from her parents like myself, then she is at higher risk of having a low self-esteem. And so this is how it can actually be important for children to have their love languages understood and encouraged and filled up by their parents. So finally, and I think this is my last slide, children are always growing and developing, as you know, which means that there's hope. What's really bad today can turn around and be better tomorrow. And so as long as parents can keep trying their best and maintain hope, their children will improve. As long as they keep trying their best. It's when they give up trying that their children will not improve and may even get worse. So keep encouraging and supporting the parents. And one day you will actually see miracles happen. That's it. Thank you very much. So I'm happy to take questions now.
Okay, thank you very much. That was a very interesting talk. We're just going to go to questions now. Okay, we've got quite a lot of good questions here, so we'll try and get through those. Okay. Now, what's the earliest age a GP can think about diagnosing ADD in a child?
The short answer to that would be 3 years old.
Right, thank you.
But it obviously depends on the severity of the behaviors. You know, I guess the way that I would kind of work out whether a child has, I guess, a disorder of their behavior is looking at severity levels. You know, we know that 3-year-old, the younger a child is, the more active they are, the more hyperactive they are. And it's normal for a 3-year-old to be running around almost constantly. But it's also normal for a 3-year-old to be able to actually sit down and focus on you know, a pleasurable activity for at least 5 to 10 minutes. So what we try to do is work out whether what we're seeing in terms of the behavioral profile is it comparable to the average child at that age? So, you know, is it age appropriate? And I guess when it's not, then that's when we start thinking that there could be something else going on.
All right, thank you. And also the effect of fluoxetine, SSRI. It says, I've found it useful in children in high school, bothered by symptoms and allowing better concentration. And also other people have wondered if other alternatives, because you mentioned anxiety goes with ADD, and if there are other alternatives if they didn't want to use SSRIs. But sort of what's the role of SSRIs?
I do find SSRIs very helpful, especially if a child has comorbid anxiety and or depression. Anxiety being far more common than depression. And I find that it can be very effective in conjunction with stimulant medication. So yes, it is a very useful drug. The most common one that I prescribe is fluoxetine and also sertraline. Yes, when it works, it can be very helpful.
And if parents or children didn't want to take an SSRI, I guess because of the concerns with adolescents sometimes I've heard about, are there any alternatives for the anxiety depression that you'd suggest?
There are yes, there are like the tricyclic antidepressants, and there are also the SNRIs, which I think you guys probably have more experience treating adults with. So those are alternatives as well, but I certainly have more experience with the SSRIs, and I'm therefore more comfortable in prescribing SSRIs to these children.
Thank you. And someone's asked, sorry, have you finished?
No, I was just gonna say I also have quite a lot of patients on atypical antipsychotics like risperidone. But those tend to be the population who have autism, which would be for another talk.
Oh, thank you. And also, what's your opinion of aerobic exercise effect on ADHD as add-on therapy?
I think it's great. in the sense that it helps with that sensory processing, and it helps with emotional regulation. In terms of actual therapy with regards to improving concentration and all that, not very effective. But in terms of just having a calming or settling effect in reducing the hyperactive impulsivity, as well as reducing emotional lability, yes, it can actually be quite good. And that is one thing that I do encourage a lot of my families to do with their kids, that once they come home from school, get them to do a physical activity that would then have like a calming effect on their kids.
All right, thank you. And someone's asking, the main side effects that you see from stimulant medications, do they require any monitoring? And another one related to that is, do we need ECGs for long QT, for example, on patients on the new drugs or even Ritalin or Dex?
In general, I do not order an ECG unless there is more of a cardiac issue. So, like if there's a child that who is experiencing palpitations, for example, or tachycardia, then I would order an ECG. The general guidelines kind of do not recommend ECG as routine monitoring. I mean, there's no harm in doing it, but so I haven't really needed to organize or order an ECG unless there have been some issues, or if the dose of medication I'm using is getting quite high, and I'm starting to get a little bit concerned about the possibility of prolonged QT intervals. But what I do routinely monitor is their growth in terms of height and weight, as well as their blood pressure and their heart rate whenever they come to my appointments.
Oh, thank you. Do the new drugs you mentioned, tamoxifen and guanfacine, clonidine, work for non-hyperactive ADD?
Yes, I believe that they do. The non-stimulant, the non-stimulants are a little bit hit and miss, I find. Whereas the stimulants work in about 70 to 80% of patients. And basically, if you were to combine methylphenidate and dexamphetamine together, there is a 90% chance of success. Whereas with the non-stimulants, it's much lower, and it's more around a 50% chance that it would work. Even though it could be those kids who are more hyperactive and hyper-aroused, I find that failing to respond to those non-stimulant medications a lot higher than with the stimulants.
And you mentioned the short half-life of clonidine in the lecture. Do you have a preference for the tamoxifen over guanfacine?
Yes, I tend to use atomoxetine first before trying guanfacine, mainly because of the higher incidence of side effects from the guanfacine, with regards to the drowsiness. I would say that the chances of a child getting drowsy is something like 25 to 30%, which is really quite high. We're talking about at least 1 in 4 kids. And the drowsiness, I'm talking about significant drowsiness, where the child is falling asleep in class for a couple of hours at a time, even like 2 or 3 weeks after commencing the medication at a very low dose. So because of those side effects, and I tend to try atomoxetine first. The most common problem that I've had with atomoxetine is not in the way of side effects, because side effects are very, very uncommon, but it's just no benefit at all, as though you're not even taking anything.
Thank you. And someone's asked, is it better to introduce medications early, or if there is a delay, does it not give a better outcome? So they're going to do worse if you start at 18 versus 8, I guess.
Yes, that's right. Because there have been more recent studies that have looked at brain growth by doing serial MRI brain scans. And what they've found is that the ADHD population generally have a slightly smaller brain size than the non-ADHD population. And what they've found with stimulant medication therapy over a number of years is that the treated patients, their brain size or brain growth actually accelerated and approximated the control group over a period of time, which was actually very surprising, because we've always thought that once the stimulant medication wore off, the benefits were gone, and that there were no long-term permanent benefits from the medication, apart from, I guess, what you learn while you're medicated. But it was interesting to see that the brain structure and growth actually improved with the medication. And what studies have also shown is that the younger you start a child on the medication, the higher the chance that the child can actually stop needing medication at a later age. And that's also what I'm seeing in my practice, where if I get a child starting medication at the age of 6 or 7, which is the common age group that children start, because that's when they start school, and that's when the problems become more significant, because they're not functioning appropriately at school, and that's when they end up seeing someone like myself. And that those kids have a higher chance of stopping medication once they reach the age of 18 or 19, compared to those kids that start a few years later.
Oh, thank you. We've got a few things on the natural treatments. What dose of omega-3 do you use?
Nobody really knows for sure. With that particular product, I just tell my patients to follow what the label says, which is starting off on 1 capsule twice a day for a month, and then going up to 2 capsules twice a day for a month. The studies were done on children who were taking 2 capsules twice a day for that 3-month period. And so that's what I tell them. And so that would amount to 1 gram of the omega-3 fatty acids twice a day.
That's great. And another question on dose. With melatonin for sleep, what dose, what preparation do you use? It compounded, and how quickly does it work? Any side effects, and for how long?
Okay, so with compounded melatonin, you can request any kind of dose. The standard dose is 3 milligrams. That's the same for children and for adults as well. You can try a lower dose. The standard compounded melatonin will only last for about an hour, and it usually kicks in within half an hour. And so what I advise the parents is that give it to the child as the child's about to get into bed. It kicks in within half an hour. So 15 minutes after taking the melatonin, switch off the lights, and the child has to be trying to fall asleep, because it is so mild, so weak, that if the child were to be, say, reading in bed or just doing something, it probably won't even work. And because it wears off so quickly, you could actually miss that window if the child's not trying to fall asleep. But if they are, then there's a good chance that the child will fall asleep. I'm also prescribing Circadin, which is a slow-release melatonin, and it's a 2 milligram tablet, and I found it to be quite effective. The benefit of slow release is that for those kids who wake up in the middle of the night, it can help them remain asleep and therefore sort out that issue. On top of that, I also recommend my families look at the iherb.com website, which is an American website that sells vitamin supplements, and to order melatonin from or through that website, whether melatonin is manufactured by vitamin and supplement companies. I found their products to actually be just as effective as the compounded melatonin you get here, but at a fraction of the price.
Are there any particular brands that you can mention that have worked?
Yes, the ones that I'm familiar with are one called Life Extensions, and the other one is Natural. That's spelled Natrol.
Oh, thank you. On the natural treatments, do low GI or ketogenic diets work in some children?
No.
Mm-hmm. And any dietary requirements or avoidance foods other than the preservatives and all that I guess you spoke about?
No, not really.
Mm-hmm. I think the Atkins was one of the ones originally was used, was touted for ADD many years ago, which was probably low preservative. And also ADHD and suicidal ideation and self-harm. How do you find much of a link there?
I think it's very uncommon. Certainly amongst my patients, I've only had like one, maybe two out of a cohort of nearly 1,000 patients now over my time, and I know that I've seen that many because I've actually done an audit on my practice not that long ago. But and those kids, who had significant suicidal ideation, had significant anxiety and depression. So it comes with having developed anxiety and depression as a comorbidity. However, what is very common is a child blurting out that they want to kill themselves or they wish they were dead when they're in the midst of an emotional meltdown. That's very, very common, and I might hear that almost every day that I'm at work. And I will always ask the parents, like, when the child is calm, does the child still want to kill themselves or wish that they were dead? And they will usually say no. It's only when they're upset or when they're arguing. And I say, well, that in that case, the child's actually trying to use that to get back at you as just as an argument, rather than really meaning that they want to do something to themselves.
And the other natural one is, does brain gym, which I know some of the, I think it's OTs or physios use, to stimulate both sides of the brain, help ADD, ADHD, executive functional learning problems?
Yeah. Look, I've only heard about it. I haven't seen any research about it, so I really can't comment. A lot of these things, the exercise programs, that involve a lot of vestibular activities, which are designed to stimulate your sense of balance and therefore stimulate better functioning of the cerebellum. You know, the working memory training programs that are designed to improve your working memory, or which is part of your short-term memory. The neurofeedback programs that are designed to you know, alter your brainwave pattern to so that your brain produces you know, the right sort of pattern that someone with who does not have ADHD displays, where when they're actually focusing on something. All those things do make scientific sense, or physiological sense. But unfortunately, we just, you know, when independent, unbiased research is done, they just continuously show us that they actually don't work. You know, which kind of is a bit frustrating, because I wish I could put you know, my kids in an exercise program, or getting them to play a particular computer game, you know, that can actually make a real difference to them. But unfortunately, somehow the brain is too complex for things like that to work at the moment.
Mm. And another medication question about thoughts on medicating at the weekend.
Medication for the weekend? I generally say that's optional, and it depends on what the child is like. For those kids who have inattentive type ADHD, and I should have said this earlier on, that with ADHD, I follow the DSM-5 criteria, where there are 3 types of ADHD: the inattentive type, the hyperactive impulsive type, and the third one is the combined type, where you got the intention and the hyperactive impulsivity. And out of the 3, I find that the most common type is actually the inattentive type, which is the one that's most commonly missed and diagnosed later, because those kids do not draw negative attention to themselves, because they're generally well behaved. You know, they're the child who is not disruptive in the classroom, but they're looking out the window, daydreaming and off with the fairies. But because they're not disruptive, they tend to get overlooked and fly under the radar. And it's those kids where, you know, the purpose of medication is to assist their learning, because those kids, although you could say it's a positive that they are not disruptive with their behavior, they're at higher risk of having learning difficulties, such as dyslexia, unfortunately, and quite significant levels of dyslexia as well. And so, um, you know, it's not all rosy for those kids who are inattentive. And so medication on school days where they're learning to enhance their learning obviously makes sense. For weekends, you know, if those kids are not doing any learning activities, then I say, well, it can be optional. But for those kids who do have significant learning difficulties, you know, what helps them improve on their learning is daily repetition. You know, with dyslexia, with dyscalculia, which is trouble with maths, it's daily repetition. Unfortunately, that's how the brain works. You know, the brain can only improve and make progress by having daily repetition. And so I would encourage those families to get their kids to continue doing a bit of homework, you know, a bit of reading, or a bit of spelling, a bit of maths on weekends to maintain that daily consistency. And in those cases, I would say, well, it would be worth continuing the medication on the weekends, just to help your child, I guess, get the most out of those learning activities and help them catch up sooner rather than later. For the kids who have the negative behaviors, the hyperactive impulsive behaviors, I do say yes, do give them the medication on weekends as well, because, you know, every time your child gets in trouble, it does affect the child's self-esteem, because often your child does not mean to get in trouble, but they do because they can't help it. And when parents start doing that and they experience how much more pleasant life is, they would often not want to stop. Yeah.
And we've got notes running late. We've got 3 more questions. We had a lot of really excellent questions. So if you can bear with me for 3 more questions.
Oh, it's 9 o'clock.
A lot of interest with this. How best to calm or slow and chill down a child when you see them spiraling out of control emotionally?
I'm sorry, can you repeat the question?
Yes, sorry, I'm reading it out verbatim. Basically, how do you calm down or slow down a child if they're just emotionally spiraling out of control? You know, one of those emotional dysregulation things I think they're referring to. Getting really angry or getting really teary, or, you know, presumably something like that.
Okay. Usually a child gets upset because they can't get their own way. And it could be asking them to do something that they don't want to, or saying no to what they want. And so if you can figure out, what it is that commonly causes the child to get upset, then try and work out if there is another way of managing it, and causing less of an emotional reaction. A lot of the time, it's an overreaction. So, like if I were to say no to a child's request, say for a treat like ice cream, the child is going to feel disappointed at some level. The child is not going to go, yay, yay, daddy said I can't have ice cream. They're going to feel some level of disappointment. The child with ADHD will overreact with that level of disappointment, and that could go into tears, or you can go into anger. So it's a way. So work out how you can actually deliver that news in a less confronting way, uh, and I guess again that involves I guess working out what the child is like. What are the things that can actually please the child or calm a child? I talked about the 5 love languages. So if you've got a lot of ADHD kids are very sensory seeking. So physical touch is a big one for them. And so maybe, rubbing them on the back or giving them a hug can be a way of reducing that. Uh, um, Another way that I mentioned earlier on is not confronting the child, because parents make the mistake of wanting to be the ones in the right all the time. And look, yes, they deserve to be in the right because they're the parent. But in a situation like this, whenever they do that, their assertion, their frustration will add fuel to the fire, and will cause their child to get even more upset. And when the child is more upset, the parent also gets even more upset because they see this as more oppositional and defiant behavior. And so at the end of the day, we then have 2 bonfires raging out of control, and everyone's unhappy. But if the parent can try to remain calm and speak calmer to the child, then the child is less likely to get as upset. And if the parent can kind of throw in a reward system as well, then that also helps. A lot of ADHD children respond very well to rewards. And so the trick is working out what kind of reward really speaks to the child. And if all parents are able to figure that out, actually, because they know their child well enough, if it could be like using a screen, screen time, for example, then they could have the star chart system where 1 star could equal, say, 10 minutes of screen time. So every time you ask the child to do something and they do it without an argument, they get a star. If they argue, then they have to surrender the star. So it works both ways, and I find that can also be quite helpful.
It is DEX and written lifelong, because it does get harder to prescribe in adults.
Yes, it depends on the person. Usually, it's about 50% to 60% of children are able to stop taking the medication when they reach young adulthood, which means that there's perhaps a 40 to 50% chance that they may still need medication as adults. And that's when I would refer them on to an adult psychiatrist to continue the treatment. And I guess it's when they're seeing an adult psychiatrist, then they might then set up joint care with GPs with regards to prescribing the medication. I don't know. Yeah.
And the last one, we've had excellent questions, so I hope we've got through most of those. That some people say that the Ritalin gives an unfair assistance to studying because a number of teenagers take Ritalin for studying an exam. I presume that means non-ADHD or ADD teenagers. Does it actually give them an advantage? Or my understanding was that if you don't need Ritalin and haven't got ADD, it actually doesn't help you, can give you side effects. What's your view on that?
Yes, and I actually agree with what you're saying, Janine. I find that not only do I find it, but I do believe that if you don't have ADHD, if you don't have ADHD, then your levels of dopamine and noradrenaline are at a normal level, and therefore, if you were to take medication that increases those levels, there's a good chance that you'll experience what this phenomenon called flooding, where it's more like the neurotransmitters are actually flooded the neurotransmitter receptors are being flooded by too many neurotransmitters, and you get this overdose effect where you get this dullness or this cloudiness in your mind, which actually makes it more difficult to concentrate than not. And that's that kind of overdose effect, when that zombie effect that the public like to talk about, where it's like an overdose. And so, yeah, I don't think that, teenagers who don't have ADHD, when they take the medication, I believe that it actually doesn't really do very much for them at all. I don't think it gives them an unfair advantage. If anything, it could even give them a disadvantage.
Well, thank you. And thank you very much for your patience with our technical problems, and also for staying back late for our webinar. And we've had a really interesting webinar with some great practical advice, and we had a very big response, a lot of interest in it tonight. So it's obviously a very important topic that we see in general practice. So thank you, Dr. Ong, for such an interesting and useful presentation. And also thank you to Bertha and Susan for all the behind the scenes work that they do, organising it and running them. They all run smoothly, and if there's technical hitches, they can even sort of resuscitate it. But they do a great job. And thank you everyone for attending. And you'll receive an evaluation link in your email box shortly. So please ensure that you complete the evaluation so that you can obtain your CPD attendance points. And we look forward to seeing you at one of our next webinars, which are all on the you can look them up on Google, but please on our site. But thank you again, Dr. On. That's a really interesting evening tonight. Thank you.
Thank you very much. Can I just make one very final comment?
Sure.
To the GPs, I actually should have said this earlier in the body of my talk. For you as GPs, if you come across a patient, a child whom you suspect could have ADHD based on some of those behavior patterns that I've talked about, what I would suggest is that you look at referring them to preferably a developmental pediatrician, but because developmental pediatricians are few and far between, they therefore have very long waiting lists, like I do. Then look at just sending them to a general pediatrician or a psychologist, like a child psychologist. What I often, I guess what I would suggest is that get them to book in with a pediatrician, and while they're on the waiting list, see a psychologist in the meantime. If things improve with the help that they get from the psychologist, they can always cancel their appointment with the pediatrician.
Yeah, no, I think that's very reasonable and good advice. Thank you. So thank you, Dr. Wong, and thank you to everybody, and we'll hope to see you at our next webinar. Thank you.
Thank you very much for having me.
Pleasure.
Good night.